Today, we are discussing a very important topic. Topic that touches on the life of every Nigerian: healthcare service delivery, the right of patients in Nigeria. We are looking particularly at the right to consent, right to confidentiality, and emergency care. And we have no any other person to do justice to this topic than our very distinguished erudite professor of medical law. He is Dean of Faculty of Law, University of Abuja, and also the Director, Institute of Medical Healthcare, and also the President of Lifeline Center for Medical and Health Rights Advocacy. Today, please, Nigerians, listeners, join me in welcoming Professor Nwakwe Abugo. Professor, welcome, sir.
Thank you, Barrister Nifade.
Thank you, sir.
I'm happy to be here.
Yes, sir. It's really a rare privilege to have you in the studio. Like you have heard, particularly in the case of the week, three issues: consent, confidentiality, and emergency care under our Nigerian healthcare system. I want you to say something. The case of the week practically illustrates the issue at hand. Yes, sir.
Thank you very much. The issue of consent to medical care is so fundamental to the right of a patient, to the extent that it can be traced back to even our fundamental right to life, and our fundamental right to dignity of the human person, and our fundamental right to liberty. In fact, there are so many fundamental rights in the Constitution that can directly be connected to the issue of consent. Why do we need the consent of a patient before his treatment? The reason is that every patient is autonomous. Every patient is an autonomous individual.
It's an autonomous being.
As an autonomous being.
Yes, sir.
And as an autonomous being, nobody can touch you or treat you without your consent firsthand and obtained. And the rule is so serious and clear,
yes,
that no matter how beneficial
yes,
the
sir.
treatment might be,
yes, sir.
no matter how innocuous the treatment might be,
yes,
no matter how stupid the patient might be, the patient might be in refusing treatment without consent, no matter how stupid he is, you still have to seek his consent.
Very good.
And so every individual, being autonomous, has a right to determine whatever happens to his body or his mind or his soul or his spirit.
Very good, sir. And looking at the law, we have come to see that in modern times, the issue of consent, unlike the normal consent, I want to treat you for malaria, I just begin to administer drugs to you. Do you agree? I agree. So the law has now drifted from that to informed consent, that the patient must adequately understand the nature of the consent that is being given.
Yeah, thank you very much for even getting to the level of having to know the difference between consent and informed consent. Is a very good way to start.
Yes, sir.
Because in Nigeria, we have researched, we have inquired, and we have reviewed the entire body of Nigerian laws, the legislation, the judicial authorities, and even the code of medical ethics in Nigeria 2008, and we have come to the conclusion that Nigerian law prefers informed consent.
Informed consent.
Yes, to ordinary consent.
To ordinary
now
consent.
We need to define ordinary consent is consent to touch and consent to procedure being prescribed by the medical personnel.
Wow. So let Prof, before you go on, I like the way you started. You are trying to properly demarcate that there is a difference between I agree for you to touch me.
Yes.
Than the difference that I agree for you to go ahead with the intended procedure.
Yes.
Yes, sir.
Yes. Now for consent means that you have secured the, let's say, the consent or the assent of the patient for the touch and for the procedure which you have explained. Yes, that is consent.
Yes, sir.
But informed consent is consent given after all information relating surrounding the treatment is given to the understanding of the patient and the patient gives assent. So informed consent means information plus assent.
Wow.
Equal to informed consent.
Wow.
And the information which you need to give to the patient for him to be able to consent involves a whole lot of things, which is covered even by Nigerian law, section 23 of Nigerian National
Health Care
Act, the National Health Act of 2014,
yes,
provides that a user of health facility, which you call patient now, thank God that your program is user.
We are still going to dissect that section 23,
yes,
vis-a-vis section 20 also that talks about emergency care.
But
now, before we get there, sir,
yes,
dear listeners, to consent, your right to confidentiality and your right to emergency care. Let I prove, sir, there is this issue of, can a consent be obtained by fraud? Now, because of research, we understand that some doctors administer treatment, medical personnel, they obtain consent by fraud, which is against our law. I mean, section 310 of criminal code talks about fraud, and when you take something by deceit. So I'd like you to also expound on this before we go into section 23.
Thank you very much. The real consent. That consent must not be obtained by fraud, must not be obtained by deceit, it must not be obtained by lying, it must not be obtained by promise of advantage, it must not be obtained through threat of violence.
What threat? That
yes, threat of violence, and fraud in any means, you know, so that at the end of the day, a fraud that is obtained through deceit or threat of violence or even promise of advantage is not real consent. Such consent is vitiated at law.
Wow. Yes. So the consent has to be free.
It has to be free, given freely, given with all the information given before, and the patient understands the information. Now let me go to the information that is necessary to be given to the patient. The first information that the patient requires is the state of his health. If you go to a medical doctor or a hospital and they examine you, after examining you, you are entitled to know the state of your health. It's only when your state of health is so bad that disclosing it will cause more injury to you than doing favor to you, that the medical personnel will be entitled to withhold that information, exercising what is called therapeutic privilege. Where
so there are situations
where you can withhold information so that it will not cause more harm. If after examining you, God forbid, and they find out that in the next 2-3 hours
the man will go,
it will be stupid of a medical personnel to say, what I'm seeing now is that in 2 hours we die, you know. In that case, you find a way around it to hold this information, and then apart from the state of your health, you're also entitled to the diagnostic procedure that
status of the patient,
and the procedure that is being. Now remember that diagnosis starts with physical examination, with the history of the patient, and so on and so forth. Where diagnosis is a simple one, it ends there. But some diagnosis will even go into surgery. If you are having a bone marrow issue, the diagnosis may even get into surgery to extract the bone marrow. For even go for histology or go for laboratory examination, you may need to go into surgery. In such cases, consent comes in again. Consent inside consent, and in any case, that the diagnostic procedure that you are suggesting, the general diagnosis is physical examination and history of the patient. When the diagnosis goes beyond that, it is the medical patient that will not propose which type of diagnosis that we are requiring. You need to do that. Then, after the diagnosis itself, the type of treatment you are proposing, you need to explain to the patient. Is the treatment going to be through tablets? Is it going to be injectables? Is it going to be lifestyle changes?
So there you will now explain the benefit, the risk, the causes and the consequences of each of the options that are available to you.
It is when you give these options. For each option, the benefit and disadvantage.
And the risk.
And the risk involved. And so on. Then you now go all over them. Then the last one that is so intriguing is that you need to inform the patient his right to refuse treatment. Which means you must not impose
the treatment no matter how beneficial it's going to be.
And no matter how no cost, no matter how harmless the treatment might be,
you must not
even go ahead. You must tell him that even after all this, you have right not to be treated. And again, the one that interests me so much, that is an innovation in the National Health Act, is that he should know the probable cost of treatment. It's only in this country that patients go to a hospital and they are not told the the proper course of treatment.
You know,
and the course of treatment is taken as if it's something from God that you cannot inquire into. No, every treatment is composed of out-of-pocket expenses of the hospital and then the professional bill. You know?
Leonard Prof, you are really on point. And you know, I was going to ask you that in spite of what you have explained, let's look at the Nigerian situation. I mean, this thing sounds very good, it looks very good on paper, even in spite of the fact that the National Health Act is there, 2014. These are our laws. How practicable are all these in the real terms in Nigerian situation?
Yeah, we must also understand that we're in Nigeria. And let us go to the doctor-patient ratio as prescribed by World Health Organization. The doctor-patient ratio as prescribed by World Health Organization is 1 doctor to about 700 patients.
1 to 700?
Yes.
Wow.
But what we have in Nigeria is 1 doctor to about 7,000 patients. So under
grossly inadequate.
Yeah, grossly inadequate. So what we have in the law is the ideal situation. In fact, I have had a case of a woman that came from far north and asked me, how is it practicable for her to apply this section 23 when she goes to the hospital in the morning, sits down and starts attending to patients from morning till 4 p.m. She wants to go and take breakfast. Patients are still crying. From 7 p.m., patients are sitting everywhere crying. Doctor, help me. In that type of situation, what do we do? So as we look at the law, the way it is, and the way we expect it to be, then we should also understand that we need to do something drastic about our healthcare system.
The 1 to 7,000 per patient ratio that we have,
yes,
the little doctors that we have are still jackpying.
Yes.
They are still jackpying. They are going abroad to seek greener pasture. So, I mean, it's a terrible situation we have in our hands.
It's a serious
It's a
crisis.
dead crisis we have
Crisis
in
on
our
our
hands.
hands.
So,
and unfortunately, those who should understand, I even believing that Nigerians are training doctors for foreigners.
For foreigners.
We have we're exporting doctors.
Yes.
When here we don't have enough.
So clearly these laws
Yes.
are impracticable in a way. What do you say about that?
We're entirely practicable, but what we expect of
It's a minimum standard.
What we expect of every medical personnel is not that you must execute all this to the nearest 1 cent. What we expect is that competent care. Do you see your patient as a human being? Do you treat your patient with reasonable care and skill? The fundamental rule of doctor-patient relationship is that you must treat your patient with reasonable care and skill. By the time we analyze the meaning of care involves even smiling when you pass through a patient. How come that the patient will say, "Good morning, doctor,"
You are not answering.
and you are not answering?
You are frowning.
Which means you're already looking at that patient as a cadaver.
Maybe the doctor has not even been paid in some situation.
You know, when a doctor answers your greeting, you feel like, which means this man still see me as a human being, which means I'm like to survive. But when a patient says, "Good morning, doctor," and you look at him without responding, the patient will say, this man that knows me every in and out, all my organs, all my nerves, all my arteries, which means they only see me as a cadaver.
Let them, Prof, we have a lot to talk about.
Much.
There's one other issue that is so germane. Talking about consent is to break the issue of consent down to say consent in that section 23 of National Health Act is now saying that consent must also be in the language that the user understands and to the level of his literacy.
Yes.
Now, I'd like you to talk briefly about that before we move away to confidentiality. Looking at the Nigerian situation where even the people you consider literate, sometimes they are not literate when it comes to some terms. Like, I mean, as a legal practitioner, you know, not everybody know their rights. Now, you're not talking about medical care also. Not everybody understand what it involves when it comes to medical care. So, where will a doctor breach or go over that line of consent when it comes to literacy?
Arguments of medical personnel and argument of what we call medical paternalism. That is, those who argue that what the patient has to do is just leave yourself to the doctor to do the best in your interest. That is what we call medical paternalism.
Assuming the doctor knows
that
all.
the doctor knows all, and the doctor is not there to harm you.
Or experiment with your body.
That argument says that no doctor puts on his clothes in the house, takes his bath, wears his stethoscope, and saying, today I'm going to kill a patient. No. It is presumed that every doctor means well for the patient. And so the doctors are arguing that since we mean well for you, you don't even understand the intricacies and the high-falutin procedure that's involved in medical procedure. Just hand yourself over to us. Let's do. But it's not always the case.
It's not, sir.
The issue of autonomy is so fundamental that it goes into the fundamental right of the patient.
Yes, sir.
And so no matter how well the doctor means, he must still seek the consent.
The right to dignity
the right to dignity and respect the consent of the patient. So what we mean is that if the doctor is practicing in a local environment, maybe a youth service doctor that practices outside his local environment that can understand the dialect of the villagers, we will need an interpreter. We need an interpreter because nobody gives consent without understanding the situation.
Exactly.
We must comprehend into every aspect of the treatment that is being suggested before we can pick and choose. Otherwise, that consent will not be a real consent.
Let's talk about right to confidentiality of their patient. Quality of information would we say it qualifies for a confidential information?
Of National Health Act makes a provision, concise provision, relating to the right of a user, the right of a patient to confidential information. It provides that all information concerning the patient, relating to the state of his health, relating to his treatment, and relating to where he's being treated are confidential. What it means is that there are three legs or three elements of confidentiality under Nigerian law. First and foremost, the state of his health. What is diagnosis? Is he suffering from epilepsy? Okay, if he's suffering from epilepsy and he's coming in to your office, you now tell your friend that please let me go and attend to that epileptic young man. Do you understand?
That's a breach.
That's the breach of his right to confidentiality, because the state of his health is confidential. Whatever he's suffering, even if he's suffering from one-night malaria, the state of his health that brought him to that hospital is confidential. Now, the other one is the mode of treatment, the cost of treatment. And the other day, I have treated a man with a tablet over 3 weeks, and now I'm proceeding with injectable. For the past 4 weeks, I've been giving injection, and nothing is happening. That is confidential. So the law says the status of his health, the method of treatment, and even his presence in your health facility should not be disclosed. It's confidential unless there are reasons to do that, which is provided under subsection 2.
Where you have a very verbose individual practicing as a legal practitioner, definitely medical practitioner. He will run foul of this.
No. It's part of their ethics. If you watch a true medical practitioner, they are very, very reserved people. Because even if the person drinks, he drinks with a lot of circumspection, and he doesn't drink whenever he's on duty or reasonable time within the time is. So there will be no cause for him to be loquacious and be very flippant with information. Yes. So the issue of confidentiality, I know that in Nigeria, not many cases, not many civil
thoughts are arisen from this issue.
But do you know that under section 27 of National Health Act, there is a very severe criminal offense for breach of confidential information on the patient, which says that if you breach it, you are liable to at least 1 year imprisonment or 250,000 naira fine, or both of them. So this is one of the few areas where the National Health Act made provision for penal consequences.
Wonderful. Before we go to the other issues, is also the fact that must the information be personal for it to be confidential? Because one of the requirements here is that if the information about the patient, if it's personal, it means then it qualifies as confidential. Then if the disclosure also will cause injury to him as a person, must also mean that it qualifies as confidential information.
We don't inherit the confidentiality. The fact that your dad had a right to confidentiality does not mean that you are the person entitled to it. The only thing to emphasize the importance of confidentiality is that the confidential information that comes to you as a medical personnel, you are entitled to keep it forever and ever, even if the person dies.
Wow.
Even if the patient is dead, you must not disclose, because any disclosure may injure his estate or injure the state of mind of his relative and so on and so forth. So that particular right to confidentiality survives even the person who is entitled to it.
Wow. We'll be looking at the issue of emergency care, which is the third leg of our discussion. Emergency care in Nigeria. But learned professor, sir, we are talking about the issue of medical emergency care in Nigeria. How adequate is emergency care in Nigeria?
The issue of emergency care is a very delicate one, because not even everybody knows the meaning of emergency. Many people confuse very critical medical condition to emergency. And I want to say straight away that the fact that somebody is receiving treatment in ICU, intensive care unit, does not mean that it's in emergency. Emergency brings a situation which requires immediate attention in order to recover life. To the extent that if life is not recovered immediately, irreparable loss, including life, may be done. That's where emergency comes in. And now we cannot even have permanent emergency. So that what we mean is that once you're able to recover life
at that time, it ceases to be emergency.
It ceases to be emergency.
And what is
even if the person goes into coma for the next 1 year, it is no longer emergency situation. We know of one American Israeli Prime Minister, Ariel Sharon, that was in coma for about 12 years. We cannot say that he was under emergency care for 12 years. So what we know is that all emergency cases arises usually outside the hospital. It's only in few cases that you see emergency cases arising within the hospital. If somebody fails in the house, or somebody has a fish bone, across his throat, or something, or somebody has accident and need to stop the flow of the blood, the loss of blood save at that time. Now, when emergency situation arises, most of the time, the medical personnel or you may not have all the facilities. You may not even have your stethoscope, you may not even have your thermometer, you may not even have some bandage, but you do what you can in order to save life. So that all emergency situation is to be examined in relation to the time, the injury itself, and the personnel that are around. If you are around emergency situation and you are just a learned lawyer, you are not educated in medical science, the way you are going to attend to it will be different from the way a medical personnel will attend to
and
it.
That also,
you may be attending to it with native intelligence and traditional wisdom. But the medical personnel will be coming with medical background. Like CPR. Like I keep saying, many Nigerians don't even know how to attend to CPR situation. Even as learners as we are, I keep saying, many of us don't even know what is CPR and how to go about it. But if it's a medical personnel attending to an emergency situation, the way he handles it will be examined and determine the legality or otherwise, the negligence or otherwise of it will determine on his level of knowledge as a medical personnel. So not the same test or the same yardstick that we use for non-medical personnel that we use for medical personnel.
Wonderful. I mean, looking at the National Health Act, it seems like that law is comprehensive to an extent on all these issues we have raised. And let's look at, I think Section 20 of that Act penalizes refusal to offer emergency emergency care. Now, but let's look at that section vis-a-vis the compulsory treatment and care for victim of gunshot Act also. That law also make adequate provision for emergency care for victim of gunshot. But in spite of that, in spite of these two laws, many Nigerian healthcare professionals still run foul of who require emergency. I mean, not too long we saw a case of a lady that had an accident. I mean, she was a victim of one chance within the city, and she was rushed to the medical facility, and they were demanding for police report, demanding for all these things. So let's look at it. What is the really penalty for failure to attend, and how should we go about it?
The National Health Act has very good intention by making provision under Section 20 that under no circumstance
Should you refuse?
should a medical facility or healthcare provider refuse emergency treatment to any Nigerian or any user of health facility. That's a very good intention. The intention is that whenever anybody presents himself or when any emergency situation presents itself in any Nigerian hospital, whether it is public or private, the person should be attended to. But the question is, you set up a hospital as a business concern, there's emergency treatment, the person, you don't even know the person might be in coma. You use your drug, use your expertise, who pays you? It is in anticipation of this that Section 11 of the National Health Act make provision for the Basic Healthcare Provision Fund. This Basic Healthcare Provision Fund provides that at least 1% of the consolidated revenue of the Federation should go into that fund.
Wow.
Basic Healthcare Provision Fund.
Wow.
And now this minimum of 1% of consolidated revenue fund of the Federation, about 50% of it should go to training and retraining
Of
healthcare
practitioners.
personnel, and then some percentage will go to the Primary Healthcare Development Agency for primary healthcare generally. Then 5% of that fund should go to emergency treatment. You can see how the Act anticipated that there should be a fund, and the Act provides that the National Council on Health should set up a committee to administer that particular 5% for purpose of emergency treatment. But the problem we are now having is, how is this 5% being administered? I can assure you that the interpretation of emergency situation, emergency treatment has
been abused.
It has been abused. It has been abused from left, right, and center, either from Federal Minister of Health or from medical personnel or otherwise. Let me give you an example. At a point, that 5% of considered revenue fund have been used to obtain ambulance. And some of them have been used to even fight epidemics in Nigeria.
So people
but the law, Section 20 say emergency treatment. Ambulance is a treatment. Fighting epidemics is a treatment.
Of course not.
So that's the problem. So where do you expect this healthcare provider to get the fund? The intention is that after you have finished the treatment, then you can now go and bring your record, and then you'll be refunded.
All cases that the refusal is due to the fact that you don't know the victim. That not in all cases.
Yes. Now I'm coming to that.
Yeah, because obviously most healthcare practitioners, most of them are just ignorant of the law.
Yes.
And they just want to act.
And they are even ignorant of the duty.
Yes, or impose on them.
The Compulsory Treatment and Care for Gunshot Victims Act of 2017. Yes, that is a very is a legislation that came after so many efforts and so many circulars between the National Health Act. Yes, between the Federal Ministry of Health and even the police. Do you know that after this law was made, the Federal Ministry of Health wrote a memo or a circular to Nigerian police. The Nigerian police wrote a signal to all police formations in Nigeria that they should start enforcing that particular law. But yet, up to today, there is lack of awareness of that particular provision. So what we're saying is that in this country, the problem, Nigeria is not a legal void. Even as in a new area as medical law and ethics, we still have a lot of robust legislation and robust legal system. But awareness is a problem, and then the political will for enforcement is another thing. Imagine an average policeman will not know that there's that type of legislation. See what happened to the lady you are talking about in a hospital where somebody was brought in. You are still asking, and that was not even gunshot wound.
It wasn't a gunshot.
It wasn't a gunshot.
She was pushed out of
why
one chance.
Looking for police report, and that particular act provides that once you are brought in with a gunshot wound, you must be attended to immediately without asking for police report, without asking for deposit. And very high criminal offence was provided for anybody, either security or hospital officers, that default in executing that particular law.
In spite of the robust provisions in this legislation, you still find that many policemen, many healthcare practitioners are not aware of this. And yet, if you have people who are victims of either gunshot or accident, you rush them to any facility, you find that the practitioners are still asking for, demanding for one report or the other, delaying the provision of emergency care.
I think what should happen? We legal practitioners should also have to come in, because if we activate the law, what if we activate the criminal procedure process that is provided in that
where
law?
There are breaches.
Yes, where there are breaches. You know, these days I keep telling those who care to know that in Nigeria, as far as breach of medical right is concerned, we believe we should sue everybody. This idea of ADR, alternative dispute negotiation, and this thing is not right for Nigerian medical rights enforcement. Because the more you sue, the more we are here, the more you see it is reported in radio, reported in television, reported in newspapers, and everybody will get aware, and everybody now know that it's no longer going to be business as usual.
Yes, Leonard Prof, you have an NGO that have been in the space that is offering this kind of service. You know, just like we do here also, multi-door advocacy initiative. What we are doing here is to also educate Nigerians, enlighten them on their right. You also have an NGO. Can you share with us some of your experience, life experience? I know.
Yeah, thank you very much. Having around,
yes,
like I said, I'm the president of Lifeline Center for Medical and Health Right Advocacy. Okay. Our job is to create awareness and advocacy, awareness, and even enforcement. I say I'm also the president, the Director General of Institute of Medical and Health Law. Okay. We have been around. The institute was registered for training and certification, and for international best practice, enforcement, and defense. You know, I don't want to use the opportunity to say that our conference is coming up just next week between Monday and Tuesday.